Hello and good afternoon to our audience members. Welcome back from our break. Thank you for joining this session today dedicated to exploring the stigma that is present within the healthcare system. As a reminder for our audience members, we are welcoming your questions for an audience Q&A session, which will close out this session today. You can submit any and all questions in the question submission box present below this video feed. Your questions can be anonymous, or you can assign your name to those if you so please. Additionally, this session is approved for continuing education credit, but instructions for claiming that credit will be provided at the conclusion of the summit this afternoon after our closing plenary. And with that, I am delighted to introduce our panelists this afternoon. First, we have Deborah Finnell. She's a professor emerita at Johns Hopkins School of Nursing. Her nursing career has focused on providing clinical care to persons with mental and substance use disorders and preparing the next generation of nurses to care for this population. Her work is grounded in the neuroscience of these disorders and the brain-based drivers of stigma. She is president-elect for the Association of Multidisciplinary Education in Substance Use and Addiction, also known as AMERSA, and serves as associate editor for their journal, Substance Abuse. We also have Richard Bottner. Richard is a certified physician's assistant, a doctor of healthcare administration, and the director of quality improvement and patient safety at the Colorado Hospital Association. Richard is exceptionally passionate about effective, efficient, and interprofessional acute care in hospitals nationwide, including advocating for appropriate substance use disorder and mental health care. Dr. Bottner was the first physician assistant in the country to be certified to teach the buprenorphine X-waiver curriculum through the American Academy of Addiction Psychiatry and has a strong interest in and passion for reducing the stigma associated with substance use disorders. Dr. Bottner was the founding director of the award-winning buprenorphine team, the first acute care hospital-based opioid use disorder treatment in Texas. And it is also my pleasure to introduce the moderator of today's session, Cheyenne Johnson. She is the executive director of the British Columbia Center on Substance Use. In her previous roles as director of clinical activities and development and founding director of the Addiction Nursing Fellowship Program, Cheyenne has overseen the development of provisional clinical care guidance, documents and dissemination, including evidence-based clinical guidelines, training programs, practice support tools, and policy briefs. Cheyenne was born in Salmon Arm, BC, and is a status member of the Tooten-Wazenbeam Treaty Reserve in Manitoba. She completed her Bachelor of Nursing Science at Queen's University and her Master of Public Health at Simon Fraser University. She is a registered nurse and an adjunct professor at the School of Nursing at the University of British Columbia. Cheyenne, would you like to start us off this afternoon?
Thank you so much, Alana, and it's my pleasure to be here virtually with you all and moderate this discussion. I want to acknowledge before we get started that I'm joining you today from the traditional stolen and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations in what is now known as Vancouver, Canada. Before we get in, Rich and Deb, into sort of the meat of the discussion around stigma in the healthcare system, I think it's important that we start by, having a level set, really kind of setting the table around, what is stigma in the healthcare system? How does it impact people who use drugs and some of its root causes? So my first kind of opening question to both of you is can you both share how the stigma of addiction manifests in the healthcare system with a focus on primary and acute care settings? Deb, why don't we start with you?
Thanks, Cheyenne, and greetings to Rich, my colleague in crime here. I want to start by explaining the photograph behind me. This comes from a treatment program in Rotterdam, Holland. It was commissioned by clients of that first program. And on either side of this colorful picture is a black and white showing just the waves of the ocean. And they describe it as kind of their journey in addiction with being driftwood on the ocean, kind of floating back and forth with the waves and not being describing kind of the unmanageability of their life. And in the center, I'm going to move away a little bit. You see a boat that's filled with driftwood. And this is highly treasured in the Netherlands. They call it flatsgold. And it represents when people are in recovery, that they're lovingly gathered into this boat and become very treasured in terms of citizens, again, contributing citizens. And I love this picture because it really is a contrast of what we see in terms of stigmatizing behavior. With one of the opening sessions that Dr. Crendel did, she talked about the relationship between prejudice, social distancing, and stigma. And with the moral paradigm that continues to be prevalent, people are blamed and shamed for their substance use. And I won't even say substance use disorder, because I think people who use substances without having a diagnosable disorder are also subject to this persistent moral paradigm. So I think Dr. Crendel's mention also of this is quote unquote bad character is reflective of the stigma, that the prejudice, the bias that people continue to experience.
Thank you, Deb. That's hard to follow. That's really beautiful, and thank you for sharing that. And good to see you again, and Cheyenne again. I'll take a slightly different angle, which is more of a sociology framework around how we think about stigma in general, but obviously in the context of today's discussion, stigma of substance use, and that is structural stigma, social stigma, and self-stigma. I think it's a really important framework to think about when we consider how stigmatization ultimately contributes to poor patient outcomes. So, structural stigma is really a fancy sociological term for policy. And policy exists at the institutional level, it exists at the local level, the state level, the federal level. And there are many policies that we humans, right, policymakers are at the end of the day human beings. And there are many policies that we have on the books that ultimately manifest in negative clinical outcomes for people who use drugs. So just a couple of examples that we can maybe talk a little bit about later. We know that there are cases where patients who are engaged in the buprenorphine program for opioid use disorder are asked to stop that medication in order to receive liver transplantation, perhaps related to hepatitis C from intravenous drug use. We know that patients who have infective endocarditis and need a valve repair surgery are often denied that valve repair surgery by cardiothoracic surgeons because they're at risk for potentially, the stigma would tell you that they're at risk for having repeat exposures and recurrence of disease that would make that initial repair, quote unquote, not worth it, right? That's a great example. We know that for birthing people who have a history of substance use, who go into the hospital, there's double stigmatization because the birthing person who may have substance use history is stigmatized by staff. And then oftentimes when that child is born, they're placed into state custody. So these are policy implications that ultimately manifest themselves within our healthcare settings. Social stigma is an important one to talk about, and that's the one that we often think about when someone says stigma. We think about social stigma. How is substance use portrayed in the media, in the movies, when we're having conversations with loved ones and friends who maybe have no clinical or medical background at all? That conversation is often not a positive one, and that's the root of social stigma. And then when you go as a policymaker, again, at an institutional, local, state, federal level to make policy, you bring that social stigma with you. You bring that misinformation, misunderstanding that has sort of surrounded you and drowned you for years when you make those decisions. So it directly feeds into structural stigma. And then, of course, self-stigma is, I think, best described as how patients who use substances and use drugs feel about themselves as a direct reflection of inadequate systems of care because of structural stigma and social stigma. So imagine having a diagnosis, let's just call it diabetes, and that your diabetes diagnosis is so heavily stigmatized that structurally you cannot get the care you need. No matter what you do, you go to the hospital, you can't get insulin, you can't get diabetes education, you can't get follow-up care when you leave the hospital. That's what people who use drugs face almost every day across almost our entire healthcare system. And so eventually it leads to this kind of phenomenon that sociologists call the why even try effect. And it really explains when I first started doing this work and I saw some of the profound hopelessness that people who have used substances for a long time often have. The core of that is that we in the healthcare system haven't set up a system of care that builds trust, that builds community, and that ultimately delivers care. So I could go on about this forever, obviously, but I think it's fair to say that stigma, while we often talk about it as kind of this out in the ether thing that's not tangible, it actually is tangible because it is directly responsible for poor clinical outcomes.
Thank you both for helping to set the table. Maybe to dive in kind of a little bit deeper, and Rich, I really like the categories that you've described around sort of structural, social, and self-stigma. And maybe to get to some of the root causes, in terms of many of us here are healthcare providers, health professionals working in research and areas around substance use. Can you both share with me maybe a little bit about your personal experiences in your medical education? What was lacking? What was perpetuating stigma, and some of the major challenges that still exist today in health provider education around substance use and addiction?
So I'll kick this off, as this is an area of continuous consternation for me. When I was in school, I had limited experience in the clinical setting, and even less in my theoretical coursework with respect to substance use. We had a course on mental health disorders and problems, but again, very little with respect to substance use. It was in my graduate studies that I really became immersed, and mostly because of my own interest in the area. But I think, though there have been efforts to increase content in really across all healthcare curricula, we still have limited content in nursing, in medicine, in maybe a little bit more in social work comparatively. But there's really been not sufficient attention to this content. And I think the other problems that fuel this is that when students who go into a clinical setting have preceptors who similarly have not had this education, and also who have the kinds of attitudes and perceptions that we would not want to have our students exposed to. So they have negative perceptions, they are not functioning from an evidence-based perspective or a science-driven perspective. And where there's more attention to some of the other chronic and acute medical or healthcare conditions. So I think to kind of the bottom line is we have a long ways to go in terms of our educational system. And I would include that not just higher education, but also exposure in elementary, middle school, and high school education as well. Rich, your thought?
Yeah, I wholeheartedly agree. And, Deb is bringing the perspective of nursing. I'm bringing the perspective of PA. And really all three of us are strong proponents of interprofessional education and interprofessional practice. And so I'll start by saying that this is a pervasive challenge across all healthcare education. So, oftentimes we use the term med ed and people think medical school. Medical school has this problem too, but so does PA, so does nursing, so does pharmacy, even professions like social work, which you wouldn't expect to necessarily have some of these challenges. They probably have a little bit less, but across the health professions, this is really a challenge. And in the interest of time, I won't go into the full story, but it's fair to say that I am not a likely person, or was not a likely person, to ultimately be here having this conversation with you today. I'll steal a phrase from Bob Ross. Who doesn't love Bob Ross? It was the happiest accident that I ended up working in this field. And I worked in law enforcement in my late teens and early 20s. I was a firefighter and an EMT before I went to PA school. And the amount of bias and stigma that I developed over the course of working in emergency services was pretty extreme with regards to people with substance use disorder. And you would imagine that going through a clinical training program, that would have been reversed or changed. And in reality, it was actually reinforced in so many different ways in both my didactic training and my clinical training, for all the reasons that Deb mentioned. And that is not unique to my PA program, right? Again, this is really pervasive across all of health education. And it wasn't until I started working in Austin and actually started doing this work through readmission prevention, so really more of an administrative focus, that I truly understood the benefit to the patient, to the community, certainly to the hospital system, but that's not the point. The point is that treating people with substance use disorders and people with history of drug use as people and not as problems is the answer. And we do not teach that. Now, I agree with Deb completely. It is changing. Change is slow. There was a wonderful short commentary that was published by a few students from Yale earlier last year, I believe, where they basically lobbied, if you will, the AAMC and asked them to change the shelf exam for medical students because a lot of the questions were written in a stigmatizing way. That probably wouldn't have happened 5 years ago, let alone, last year. And my understanding is AAMC has made big changes in that direction. So there are lots of conversations around this. I think people are engaged around this. But if you work in health education, and just to echo what Deb said, this is not just if you're sitting in a dean's office or if you're a full-time, academic or faculty person. This is across health education. The point that Deb made about preceptors is so important, because even in my example where my didactic training left some to be desired in this regard, even if we fix that, and we consider the education system fixed because our lectures take out some of the stigmatizing language and we sort of lean into it more on the didactic side, there's still that practical component that's so important. And our preceptors are not getting this type of education. I would guess that in the audience today, there are few people who are solely in the role of sort of clinical instructors in the field. So I'll end by just saying that this is paramount. We can't change the future of our system of care around substance use if we don't focus on interprofessional education. That's where this starts. It's a long game. It's a long-term investment in our workforce, but we have to do it. And I'm confident we'll get there, but I wish it could be faster.
And I just would, Cheyenne, I'd just jump in too to say that I think we have an opportunity for people with lived experience to participate shoulder to shoulder with educators and with preceptors in helping to increase or enhance the education that providers are getting. And that as Rich mentions, and I think to reinforce, this should be an interprofessional team approach. And I think people with lived experience, our peer recovery coaches or advocates should be considered part of that interprofessional team.
Thank you, Deb, and thank you, Rich, for that. I see Rich giving a big thumbs up to your comment around engaging people with lived and living experience. And yeah, I totally agree. I think when I've been involved in teaching nursing students and others, if you bring a patient partner, somebody who's gone through it, can speak to how stigma negatively affected their care experience, their willingness to engage in care, and in many ways is a very traumatizing experience for people that for other conditions makes them less likely to want to engage, go to the emergency room, see their primary care provider, etc. You both touched on obviously the lack of the foundational training, the kind of didactic areas that we would learn across any other chronic condition. Like, you know, every physician assistant and nurse and pharmacist comes out with a good understanding of diabetes and how to manage diabetes and asthma and how to manage that clinically. There's still a long way to go. But maybe kind of shifting into some, you know, clinical pearls and some great advice for our audience members today. You know, you both touched on the role of preceptors, also the role of our colleagues, where in a day-to-day clinical environment, many of you will see your own colleagues on your interdisciplinary teams, people in hospital and community settings, perpetuating, stigmatizing behaviors upon their patients or within the care teams. Can you both give some advice for if you're in a clinical setting and you notice somebody perpetuating some stigmatizing language or behaviors, how would you address that within a team or within that individual to start the conversation around, again, as you say, Rich, caring for people and seeing people who use drugs as people first?
Rich, you want to kick this one off?
Sure, happy to. You know, I'm going to make a little bit of a controversial statement, which is that language matters, and it's controversial for some reason because there are some folks in our broader community who feel that, you know, language changes over time and it doesn't really have an effect. And I poo-poo that because language matters. How we talk about people and how we write about people in the medical record and how we talk about them, both in conversations we have with them, but also, you know, certainly in academic environments, how we talk about them amongst trainees. It's so important. And when I was in Austin, this was a cornerstone of our work, was really moving away from terms like abuse and, you know, drug abuser and things like that, and focusing on patient first language, which again, in some circles is seen as kind of controversial because it's seen as not doing enough. And I agree, that is not the answer, but it's part of it because in my experience, it opens the conversation, it opens the door to having more complicated conversations, right? We can't just jump in headfirst into the deep end with no water about some of the very, very, very long-standing and complex issues that have resulted in the situation we're in today in terms of our system of care. So what's an easy kind of upper layer, simple thing to address? It's language, right? It's very, very simple. So I'm a huge proponent for centering around language as a first step. Of course, there's many downstream ones. The other one that comes to mind is something that I kind of call countering the narrative. And so, you know, in this example, and we've all been in this situation where we are part of conversations around substance use where somebody inevitably brings up this horrible patient story with this horrible outcome, and it's full of you know, emotion and not necessarily full of fact and full of assumptions and all that kind of stuff, right? Counter that narrative. Use a positive story of a person with a history of substance use or drug use that you can bring to the table. I have many in my tool belt that I pull from depending on the situation, and they're in my back pocket. I've used them multiple times now over the last several years, and it really shifts the conversation when you can take some of that frustration that people feel and turn it into hope and show that there actually is a lot that we can do for this patient population, regardless of our practice setting. I think at the core, you know, yes, stigma is obviously a challenge. Reimbursement models are a challenge. Policy, all of these things are challenges. But I find that the frustration that exists because healthcare providers don't think they have anything to offer is a huge part of the equation. So offering hope, showing people, providers, fellow clinicians, that there is a pathway to compassion and there's a reason to have compassion is a huge part of it. So so don't underestimate the power that you have, no matter where you sit within the healthcare system, no matter what role you have. Everyone has a role to play here, and I would empower you to go forth and do, even if it's something small like changing the way you speak about people with a history of drug use. That's huge and pays dividends. Lots of ripples in that pond.
And I would just reinforce that. I think I view this in many ways. when people describe somebody with who's a diabetic, I will gently say, oh, this is a person with diabetes, or even more clearly, this is a person with type 2 or insulin dependent diabetes, to send the message that Rich relayed in terms of this is a person first. It's the humanity that we need to address, and that and to not de-identify people or identify people based on their diagnosis. And by doing that, from people that I've worked with and talked with about this, it helps to see people on the even ground. And it oftentimes people with substance use disorders are viewed as lesser than, or they're responsible for their disease, and so therefore we can kind of shuttle them to one side. But I think to remind people, we're talking about human beings, and these are people who have a disorder or a diagnosis. And then to get to the hope part, I think to also refute some of those negative attitudes about, oh, what's the point? They're just going to come back to the emergency room again or again and again. And to talk about some of those individuals' experiences that have been able to move to full recovery, again, with humane treatment, with support, and with understanding, with science-driven treatments and recovery-based supports.
Thank you both. I think some really important kind of takeaways for the group around language obviously is so critical. I agree, Rich, in the way that we interact in every space. But yeah, again, such an important role for health professionals to offer hope and compassion, and really use that trauma-informed lens. I think if people that are listening today haven't done any theory or work on trauma-informed practice, I think that's such a nice piece that goes hand in hand with reducing stigma, because you can really look at a person as a person and not necessarily their behaviors, and sort of seek to better understand what happened to them, which is causing perhaps some negative outcomes in a particular interaction that you may be having in a clinical setting. Perhaps we kind of went, at the patient and the team level, but I know, Rich, you sort of touched on these structural components as well, which are so important to reduce stigma. Again, maybe thinking around the lens of giving people some kind of key takeaways of different settings that they might work in. What does sort of a policy level, a structural level stigma reduction work look like? Can you provide us with some examples? Maybe I'll go to you, Rich, first, and then Deb next.
Yeah, it's a great question. And I might be somewhat selfish and share a little bit of the work that we did in Austin as an example here. And it's important to appreciate where we started, which was a wonderful academic medical center, safety net hospital that provided really good clinical care for physical health problems, and maybe had some opportunity around how we could better address mental health problems, in particular substance use disorder. And so there was a lot of work that went into developing clinical pathways, sort of socializing the initiation of things like buprenorphine and methadone for opioid use disorder, or naltrexone for alcohol use disorder, or whatever it might be. And you can imagine that in an environment where we weren't doing that before, to then start doing it is a bit of a shock to the system. And if anyone has ever read Cotter's Change Theory, highly recommend it. He actually has a newer book called Accelerate that's super easy. I don't like reading books. Alana knows this, but you could read it in like a short weekend. But Cotter is, a Harvard trained guy who's like the international expert on change theory. And I think a lot of the work that he has done, which has nothing to do with addiction, actually applies to this work, in the sense that when you start to do this work, when you start to peel off the layers and be that local champion, number one, others will follow. You are not the only one at your institution that cares about this. I can assure you there are others, but because of the way we talk about it and stigmatize it, folks are a little bit more afraid to come out of the woodwork and support this kind of work until someone comes along and says, hey, let's band together and start doing this work. So know that if you are the current champion or you aspire to be a champion, you have supporters, you just might not know it yet. And so once you start to build this sort of coalition, then you have a burning platform. And over time, and in our case, it was probably about 6 months or so from the time that we started doing this to the time that we were really treating patients. And it took a little bit longer to actually change culture. Now, mind you, this was 5 years ago. And with where we are at least in terms of opioids, this work can absolutely be accelerated, that we were able to develop these clinical pathways. And I think at the end of the day, if you fast forward, we really shifted our standard of care. So it's a prime example of local policy of what you can do at the institutional level. We had to work through P&T committees. We had to change policy around verifications that had to be done in order to restart outpatient methadone, which, of course, we recognize now is kind of absurd, but that was the stuff that we had to work through 4+ years ago. And so at the institutional level, at the local level, every single person who's attending this today should feel empowered to be the driver, to be the change agent that can change that local policy. And you will find champions in your peers, but you'll also find champions in the executive staff, right? Which of course is critically important as we navigate health systems and all of that. And of course, as you build success over time, which you will, then the other pieces start to come together around administrative outcomes like readmissions and length of stay and all this other stuff that I could talk about later on if you would all like. And as you start to do this work locally, all of a sudden you start to realize that others pay attention. Policymakers at the local level pay attention. Policymakers at the state level pay attention because this is effective work. When you think about the quadruple aim and what makes the quadruple aim, this work speaks to all 4 points. So it's a no-brainer once you start doing it and once you have something to show for it. It's harder when there's so much stigma behind it, right? So I guess long story short is be the local champion and build that support and know that there are people around you who want to do this work with you as well. And that's a prime way of reducing the stigma associated with it.
And I would just add, I think what we're seeing with the current White House administration is finally some influence in terms of changing the federal organizations. SAMHSA undergoing a potential name change. NIDA, NIAAA, still have the last A meaning abuse. And so I think those are not easy fixes or easy changes to change the corporate name, if you will. I think the other thing is the endorsement of harm reduction approaches that have finally begun to infiltrate the US, and following years of evidence and support that's been generated from Vancouver in particular. I think that helps in terms of changing some of the structural stigma. In our own organization, AMERSA, as was in my introduction, the association's journal is titled Substance Abuse. Many years ago, we had a discussion around this and how we can change the title of the journal, which is not an easy task. It has significant implications, but a number of years ago, we developed the trademark capital S, capital A, and small j. And that became the trademark, and that became kind of the larger font on the journal cover. And in our attempt to rebrand the journal and had an accompanying editorial that talked about why we were doing this and the challenges of making those changes in terms of language. So I think there are some things that can be done at in a local level, but boy, when we get the federal government looking at opening the Pandora's box, I think that really helps to lead the way for other organizations and other changes.
Thank you both. Yes, I think some really important structural and policy pieces that it sounds like, you know, members of this group can be involved in at any level in your clinic, in your hospital, joining groups like AMERSA or other groups in your area that work towards further educating folks around harm reduction and reducing stigma. You know, I'd also just offer kind of back to the education piece, how, you know, I've personally seen at our local hospital, how, you know, the creation of fellowship programs for physicians, nurses, social workers, pharmacists, embedding those across the system really also helps to reduce stigma, because you have trainees abound, you know, at our local hospital, at St. Paul's Hospital. Sometimes we have as many as 15 trainees on the addiction consult service at a one time going across the hospital. And they're able as trainees to, you know, work with nurse educators and others to do small in-services around stigma, trauma-informed care, and again, sort of identify those clinical interactions that may be laden with stigma and help people to unpack it and approach people in this person-centered way to improve care. We do have quite a bit of questions coming in, so I think we should start to kind of dig into these as they're really building on what we're talking about. A question has come in from an audience member really related to medication-assisted therapy and some of the stigma around the use of medication in a comprehensive treatment plan around treating substance use disorders. Could you both speak to your experience and the prevalence of this and how it's related to the moral model? Deb, you kind of touched on that around sort of the being blamed and shamed for your addiction, and perhaps some strategies on how you can talk with patients or again, talk with providers to reduce the stigma of taking medication to support people's recovery journeys for their substance use. Deb, maybe we'll start with you.
Yeah, great question. Thank you for that question. I think that the importance, again, comes to understanding the pharmacotherapy of these medications. And what I hear too frequently is, well, this is just replacing one drug for another drug. You know, when I think it does go to the moral model, because when we think in terms of people with diabetes who need to be treated with metformin or insulin, we don't use that same kind of justification. So I think understanding the how the medications work and why, unfortunately, we have to continue to be to educate people in terms of why these medications work, what's the evidence for them. And then also, you know, what I see in terms of working with people who have been referred to peer health programs, professionals with impaired practice, and the prohibition of returning to work when they're on buprenorphine or when they're on methadone. It's really, how do we get to those regulatory agencies to help them understand that people who are on medications that will support their recovery are going to be able to return back to the workplace and healthier than perhaps they were even a few years before their practice was impaired. So that's just an initial thought.
It's such an important question because this comes up a lot, especially, having worked in the clinical setting for a while. And, I like to think about it in different, through different lenses. So from a healthcare provider's perspective, my approach has always been to show the science. I mean, in my experience, there's so much misinformation. There's actually not that many healthcare providers out there who are just abundantly opposed to this, even after learning more about it. It's just that there's so much misinformation. There's no formal education like we talked about earlier, or at least not for most of the people who are currently in the workforce. And so I think it's our responsibility and our duty to share that knowledge that we've accumulated. So when I was at Dell with Alana, we developed a sort of Mythbusters document as part of the work that we were doing, and also as part of some online stigma training tools that we developed. And there are other organizations that have done this as well. So really citing the evidence, the peer-reviewed evidence that goes against a lot of these myths, and Deb identified probably the one that we hear the most, right? That it's drug replacement therapy. It's asinine, right? We don't talk about that, for insulin, for metformin, for furosemide. I mean, we would never say something like that. But for some reason with methadone and buprenorphine, we do. So I think for healthcare providers, we use the science, we use the evidence, and that's been overall pretty successful for me. The other piece is for the patient and for the patient's family member, right? So it's not just the patient that we often hear this from, it's a lot of times from family members as well. And you can't pull out a New England Journal article and show it. Some patients you can, right? But not most. And so I think there is a really important way to share that conversation to build health literacy, which again, we do for all of these other diagnoses like diabetes and heart failure, but we don't tend to do it as much for substance use, and to help patients understand the role that medications play. They're not necessarily engaged in any one of these medications for life or anything even close to that for some patients, and that it's really an opportunity to potentially achieve recovery as defined by the patient. But I also want to just caution us, because when I started doing this work several years ago, as a clinician, and sort of naive to all of this space, my headspace was any patient who has a history of unhealthy opioid use, they need to be on buprenorphine. Like, that's my goal, is to get as many patients as possible who sort of fit the bill, if you will, on buprenorphine. Right? This was Rich Bottner 4 years ago. What, of course, I recognized pretty quickly was that that's not the right approach. For patients who want to be on buprenorphine or methadone, great. I can offer you that. But for other patients who maybe are apprehensive or maybe just flat out don't want it, there's this whole other area called harm reduction that we really need to think about. So it's not my preference as a clinician how many patients end up on buprenorphine or methadone or whatever it might be. It's the patient's preference. And so, we have to preserve autonomy as we do this work. And so I just want to kind of caution us that it's a slippery slope, and especially as we look for solutions. And because, that is our healthcare system in many ways, is there a medication that can fix this? And for many patients, yes, that is buprenorphine or methadone or extended release naltrexone in the setting of opioid use disorder, but that's not all patients. So we have to just make sure that we're being patient-centered in all the work that we do.
Thank you both so much. And I think lots to unpack there. Deb, your comments around some of the workplace and return to work could be a session in itself that we could dive really deeply into. And in this piece, I also just wanted to offer, often this is a challenge for many people seeking a goal of an inpatient treatment facility to support them on their recovery journey, where many facilities will not accept patients on medication-assisted treatment, or patients experience stigma in a support group, a community support group like a NA or an AA, where other members of that group kind of stigmatize the use. And so just to point to that, there's lots of self-help groups out there for folks if they're seeking them. Maybe that's not the right one for you. There may be other groups that are more accepting. There's Smart Recovery. There's other programs that can be accessed. And also, the policy piece around inpatient facilities really needs to be supported so that more patients can, start their early journey around recovery on medication-assisted treatment and seek those components. Both of you kind of touched on the patient preference, really making this patient-oriented. Another question kind of has come in about this idea of sort of harm reduction versus abstinence, which is, how do clinicians and healthcare administrators balance these ideas of harm reduction and patient-defined recovery with perhaps, and maybe I'll challenge this question a little bit. The system sees the sort of ultimate goal of abstinence. How can we, work with clinicians and health administrators around that idea?
Yeah, again, a great question, and I think it really comes to Rich's point that this is about patient preference. We can explain, what different what different potential goals may be and how to get to those goals, but it's really not us our place to set that goal, but for us to provide all of the information that the patient and family want. And again, thinking in terms of making sure that we're clear in terms of literacy and understanding, and letting our own control go to allow in the right of the patient to make that choice.
Yeah, I approach this question with some sensitivity, in the sense that there's probably an element there that I used to believe, right? Back when I was starting to do this work and was learning about the medications and was sort of in a form of recovery of my own that I talk about from all the stigma around substance use. And I was sort of on that journey, but I hadn't completed it yet. So there probably was a piece of Rich Bottner 4 years ago that really had this, the ultimate goal here is abstinence. I recognize now that that's preposterous, right? This idea of all or nothing, number one, to Deb's point, does not preserve patient autonomy in any way, which is our oath as healthcare providers, right? We made an oath across the healthcare system to preserve certain areas, and one of those areas is patient autonomy, and we have completely stripped that away from most people who have a history of drug use. So I have a big problem with that. But even if you go beyond that, from a systems perspective, so the heart of the question was, for administrators, for payers who are saying, abstinence is the goal, how do we get around that? And I think the answer is, what's the alternative, right? If you're saying all or nothing, then you're going to, for most patients, be stuck with nothing. And nothing is where we are today. Where we are today is repeated readmissions, extended length of stay, super complex hospitalizations related to infective endocarditis, cirrhosis, the list goes on and on and on. So the alternative to that is saying, okay, what's the spectrum, right? Are we better off for not providing any kind of support for patients whatsoever, and then bearing the resource allocation that it's going to require as a health system, as a community, with regard to the consequences of that decision? Or do we meet patients where they're at in that moment? And even if it's not abstinence, it's still somewhere further along that spectrum than we would have been if we said we're not going to do anything at all. And when you start to peel away the many layers, purely from a business perspective, from an administrative perspective, you very quickly realize that the right answer is to meet patients where they're at. And actually, for many of those patients, again, not all, many of those patients will move along that spectrum over time, right? We do the same thing for insulin-dependent diabetes. We do the same thing for heart failure. The list goes on and on. Sorry, I get very passionate about this because this is the battle that Deb and Cheyenne and I and many others have been fighting for and really many people much longer than me. So I think the heart of the question is that abstinence only is not the answer. We know that. From a business perspective, we know that from a clinical perspective, we know, any angle, any lens you want to look at that question through, abstinence only is not the right answer.
Thank you both. And yeah, something I'm very passionate about, because I think when we approach this in an absence only way, it's very stigmatizing and very traumatizing for individuals to engage in care. And again, start from the start with patients. If their goal is to get a bus pass, connect them to a social worker and help them get transportation or get on income assistance. And then, as Rich, you say, you could slowly engage in a primary care setting, right? For individuals to monitor their blood pressure, to have a well woman's exam, to have their vaccinations up to date. There's so many ways that this is an entire person that may have other health challenges beyond their substance use disorder, that you can connect them and support them. And then as that trust is built and those relationships are built, there's opportunities to do brief interventions. There's opportunities to engage and offer care. It's a journey. It's not one interaction. I think it's important to look at it that way. Perhaps going back to some of the education components, there's a question that comes in really around what is the best way we should be teaching health professionals and providers about stigma. Should it be a standalone topic in continuing education sessions, or should it be something that's woven throughout different curriculum? What are both of your thoughts on that?
So my immediate response is we do not want a standalone course on stigma. I think we need to, as one of the things that we did with the curriculum at Johns Hopkins was we looked at where is there content in the curriculum that's related to things like screening for hypertension, et cetera. That's where we added screening measures for alcohol and drug use. So I think to look at where are there opportunities to address this throughout the curriculum are important. Well, not that we've been successful with this, but in terms of diversity, equity, and inclusivity, how do we address that in the curriculum? Should we have an individual course? No, it should be addressed all the way through, and it should be wherever it rises as an opportunity to address this, then it should be addressed. I think there's lots of opportunities. There's looking at opportunities, for example, of how do we describe people with diabetes? Do we talk about them as diabetics? Do we talk about addicts? Do we talk about alcoholics? And to again reinforce the importance of person-first language, the humanity, the compassion, and it should be across every patient human interaction, regardless of whatever the reason is that the person's presenting to healthcare.
I'll just say ditto, if I can. I totally agree with Deb. The one thing I'll add is I think there is some utility in, and I don't know that this is a course in and of itself, right? Like that's probably too much. I agree with Deb that this needs to be woven in throughout curricula, just like we're doing for other areas. I think there's some utility though in having at least one explicit conversation, very similar to what we're doing here. I mean, this really was one of the primary purposes of starting this summit, right? Is to give a safe space to explore some of those biases and stigma that, even for those of us who have been doing this for a while, we may have some of our own biases and stigma that still sort of percolate around and creep up every so often. And so I think for lay people, which I'm going to include our fellow clinicians and policymakers and others who don't do this work every day, you can imagine that bias and stigma exists too. So I think it's important to have some intentionality around how do we specifically address that bias and stigma related to substance use, but that's a small piece of it. I think the bigger piece, to Deb's point, is making sure that we are weaving this throughout curriculum, and making sure that case studies, exam questions, clinical experiences, et cetera, are being done in a more informed, stigma. I was about to say stigma reducing, stigma eliminating kind of way.
Wonderful. Yeah. Thank you both. And I think that's something people can kind of take away as well. If they have existing education modules, case studies, other things, that exists. You can really just look at that around, are these stigmatizing? Are these trauma informed? Are these culturally appropriate? And just work to tweak those existing components that you have, and really, as you say, Rich, work to eliminating stigma. We're getting close to our time, but one audience member asked, and I think maybe pointing them to some resources. We talk so much about the importance of language today. And do both of you have any language guides or resources you can point folks towards that can help them continue their education around this piece?
I think, well, actually there are, and I think they're going to be maybe in the Shatterproof documents that are going to be released. But there's an article that colleagues and I wrote in Substance Abuse Journal on pejorative language. Mike Botticelli has written an article on this. There's an article on, I think it's called The Dictionary, that Rich Sates, our beloved colleague, authored. But Rich, you may know of others.
I was going to offer a very simplistic suggestion, which I know sounds kind of counterintuitive, but if you go on Google, which is what I do frequently for this, I just type substance use disorder language, and you'll be surprised at the number of resources that pop up. There's a number of organizations that have charts that you can sort of adapt and download and insert into emails and messages. There's one from the American Society of Addiction Medicine that I tend to use a lot just because it pops up first when I use Google. But so yeah, I think that Deb's answer will give you more thorough kinds of approaches. But if you're looking for something kind of quick and easy, I think Google, believe it or not, is actually a good place to start. And one more name for you to look up would be, of course, now I just lost it. Oh no. Oh well, never mind. It'll come back to me in the next 15 seconds, I bet though.
And I would also say that more and more journals in the addictions holdings are including this in their author guidelines. And so they're providing examples of here's what we won't accept, and here's acceptable language. So to look at, like, for example, our own substance abuse journal has guidelines on that as well, but I know that there's other journals in the addiction holding that have those examples. 15 seconds, Rich, did you remember?
Thank you for giving me the alley-oop here. Robert Ashford, if you look up Robert Ashford, he's done a lot of writing and research around language in substance use. Thanks, Deb.
Well, thank you both so much. What a privilege it's been to moderate this wonderful conversation. Thank you so much, Rich, and so much, Deb. That takes us to time, so I'm going to just turn it back over to Alana.
Yes, thank you so much, Cheyenne, Deborah, and Richard, for your amazing thoughts and engaging commentary this afternoon. We're so appreciative that you were able to join us today. To our audience members, this does conclude this breakout session on stigma within the healthcare system. We are going to move to a 10-minute break before the second round of breakout sessions, which will begin at 2:10 Eastern Time. Breakout session 2.2, which is exploring the roots of anti-stigma in anti-racism work, will be occurring within this tab within your video stream. Breakout session 2.1 is interventions for treatment and recovery stigma. That will be occurring in the plenary and track A tab. And breakout session 2.3, addiction stigma, and the carceral system will be occurring in the track C tab. I do understand that there were some technical issues in the track C tab during this breakout session, but rest assured those have been resolved. We should be able to have that session with no issues in the next breakout. One last reminder, instructions for claiming continuing education credit will be provided at the conclusion of the summit this afternoon, and recordings of all of the breakout sessions will be made available to all attendees in the weeks following the summit. It has been a pleasure to host you for this session. Please enjoy the rest of the summit programming if your schedule allows.